So today, ladies and gentlemen, we have Dr. Naveenraj Solomon from California, Loma Linda. We'll be talking about current management of breast cancer and axillary nodal disease. Dr. Naveen, the floor is yours.
Okay. Well, thank you again for this opportunity to talk with all of you distinguished surgeons out there in Egypt. So I wanted to talk about a topic that I know is a very common topic around the world, current management of breast cancer and axillary nodal disease. So there's a lot of information I was trying to pack, but where cancer management is going in the breast has to do with changes in systemic treatment, as well as what do we do for the axilla. And a lot of this also is dependent on the types of resources and such that everybody has in their own country. So I don't have any disclosures. The objectives is just to look at epidemiology of breast cancer. And I actually searched the literature really to find in Egypt, what is the epidemiology? Because I think that's matters a little bit more than what happens here so much in the United States. But a lot of the literature I'll go through has to do with a lot of the NSABP literature and other studies that have been done in regards to management of breast cancer. So just incidents, and this is some of the data that I gathered. If there's any corrections or we can kind of discuss, but this is what I could find just by going through some papers that I found off through PubMed and everything. So in Egypt, it's the most common malignancy in women. About the mortality rate is about 11%. The incidence looks to be about as high as 38.8%. I think in 2020 was the last date that I could get the total number of cases, but there was 22,700 cases. And there's the Garbia Cancer Registry. And I guess this is very similar to what we have in the United States. That's something called SEER, which has to do with looking at cancer data through various different states in the United States. And some of the data that I saw, I found it interesting. So the mean age of breast cancer in Egypt in women tends to be 10 years younger than the United States. 19% of the cases were less than 40 years old, women less than 40 years old, versus in SEER, only 6% of the patients develop breast cancer less than 40 years old. And we also see in some of the papers that I was looking at that cases are much more diagnosed at an advanced stage of breast cancer compared to our SEER data in the United States. So does that sound about right in many of your practices?
Yes, that sounds perfectly right. Totally agree.
Yeah, and I found it interesting, such a younger age of presentation, which, that has something separately to do with screening. There's something, I think, there has to be something more biologically related versus screening related. So I found that also very interesting. So the breakdown, invasive ductal cancer, 83.2%, which is very similar to what we have in the US, invasive lobular, medullary carcinoma, and just kind of the breakdown of HER2 positive disease, triple negative breast cancer, and then luminal A and B. A couple other statistics that I found, just kind of seeing how the management is done overall in Egypt. And so looking at this paper that looked at data from 2007 to 2016, looking at just sort of 3 public oncology services that they pulled data from. I think they had data from about 5,236. They said data points, but I think that's overall patients. But just kind of a summary of what we see in Egypt is the adjuvant chemotherapy is given more often to patients. Neoadjuvant, only about 333 patients receive. So in this data set, 8.3%. And then the other thing with neoadjuvant or just treatment in general, of 321 patients that are eligible for trastuzumab in HER2 disease, only about 180 received. And the breakdown from a surgery standpoint, so it sounds like more women tend to get modified radical, not as much breast conservation, more axillary lymph node dissection, some sentinel lymph node dissections as well. And obviously the staging, presents an issue when you're trying to see how to manage this. So, more often it sounds like women present with stage 3 disease more than just early breast cancer. this is the breakdown from the American Cancer Society of some of the statistics in the United States. So when we look at stage 1 and 2, the more earlier breast cancer stages, we tend to have more patients that get breast conservation plus radiation. Mastectomy, we tend to see that more often in some of the higher stage patients. So here, stage 3, we tend to see more patients opting for more mastectomy. It's interesting, even a lot of the younger patients that I see that are, under 50 or even under 40, a few in their 30s will opt for mastectomy. So this is just kind of the breakdown of what we see in far as treatment in the United States. So kind of just touching on some of the surgical treatment, I think we all know for the breast, its management is mastectomy versus lumpectomy or breast conservation. The axilla, sentinel lymph node biopsy versus axillary lymph node dissection. I want to kind of touch more on that, but there's a lot of literature going that we need to just kind of review to look at what are the trends or what are some of the ways to move forward in this. So localization techniques for breast conservation. So for years and years, we use needle localization. So the day of surgery, patients arrive, the radiologist puts the needle in, and then we go to surgery, and then we just excise that area where the breast cancer is. And these patients will go on to get radiation afterwards. We've been moving more and more to seed localization. So the two biggest companies utilizing this is one is called MagSeed and another is called SavvyScout. So this is wireless technology. And so what happens here is patients, a few days or so before their surgery, they go to the radiologist and the radiologist puts a seed or some type of localizer in the breast, and then we have instruments to localize this in the operating room. So similar to what is often used for sentinel node, this is the MagSeed. It's a small metal seed. It's smaller than a grain of rice. And then we use this detector to look for this in the breast. There's pluses or minuses of this. One of the things is that when you use this technology, you can't have other metal instruments while you're doing the surgery. So we often have to use plastic retractors or titanium retractors so it doesn't create another magnetic field around the other metal. SavvyScout, this is another type of technology. This uses radar technology, and so the seed emits a radar signal that's picked up by this machine here. There's pluses or minuses of this one. Some people say the Bovie can sometimes deactivate this seed as well. So when we look at this, this is the kind of standard way of doing this with a wire, anchors into the breast mass. But with seed technology, the seed is here and you use your detector. And these are some of the other types of seeds that people use more and more to find this. And what we see, some of the big data with this is that you have less positive margin rate. So a lot of literature shows with using the needle, we have more positive margin versus, 17% versus 12%. And then the re-excision rate tends to be slightly higher as well in wire versus seed. Now, I don't know if anyone does this. I mean, many times what I do in the operating room is, regardless of whether I use wire or seed, I often will do shave margins after I take out the breast cancer. And so we participated in two studies at Loma Linda where, we would take out the lump and then I would do a shave margin around and take surrounding tissue. And we found that that would decrease our re-excision rate. So we didn't have to take patients back more often. And so I think, if you're going to use a needle and you do shave margins, or even if you use the seed, one or the other, you can really cut your re-excision rate much lower. So what is the sort of evolution of care in breast management? So I kind of touched on just what we're using for localization. And this is, when we talk about the evolution of care, it tends to relate more into the axillary disease. And this is the goals of what we would like to reduce. So this is a patient after breast cancer and had an axillary lymph node dissection. This is lymphedema. And so I know we see a lot of these in these patients, and it can be a very debilitating problem for patients. And so, as we know, a lot of the literature that looks at what to do in the axilla really focuses on decreasing morbidity without affecting disease-free or overall survival in patients. So I'm just going to touch on some of the highlighted literature on this, and I'll go through this as efficiently as possible so we can have time for questions. So one of the first large studies was the NSABP B4, and we refer to this quite often. And so this looked at, comparison of radical mastectomy versus total mastectomy plus radiation. And so they looked, this is a randomized controlled trial done in the 70s, and they looked at two groups. They looked at if you were clinically node positive and you got a radical mastectomy versus a total mastectomy versus radiation, or if you were clinically node negative, you got a radical mastectomy versus total mastectomy. And if you developed lymph node disease later on, you would get an axillary node dissection. They compared this as well with also total mastectomy and radiation. So this is kind of the breakdown in the schema of B4. And we refer to B4 quite often when we think about the axillary, when we think about axillary disease. So this is some of the results from B4. So if you look here, these top three have to do with the clinically node negative patients. And so you've got radical mastectomy, total mastectomy with radiation, total mastectomy in general. But as you can see, these survival curves here don't change. Now, patients with clinically positive nodes who had a radical mastectomy and a total mastectomy with radiation, you can see here the curves don't change as well between these two groups. So and there's been data that's looked at this years and years later, and the statistics still hold true. When we look at overall survival, you can see there's no change between these two groups of patients when they're node positive, whether you do a radical versus a total mastectomy with radiation, or even in the node negative, if you do a radical versus total mastectomy with radiation. What we did see is that there was increased risk of lymphedema. And so I think this is kind of held. I think we've all seen a lot of these patients. And then what they did see is that 14% of the patients that were in the clinically node negative who just had a total mastectomy, only 14% developed lymph node positive disease, and they underwent an axillary lymph node dissection. And the recurrence rate in the axilla was less than 2% for radical mastectomy and total mastectomy plus radiation. So this tells us that, there is some aspects of the axilla that is, behaves very differently. And that's even for B4, the NSABP B04 data. And when we think about how we manage now, a lot of times we will think about this literature in regards to how aggressive we need to be in the axilla. So the summary endpoints, 1,600 patients. This was the breakdown. They looked at their treatment failure, survival, and morbidity. They found more morbidity with radical mastectomy. A couple other points. They estimated that in patients who had a total mastectomy, 40% of them were estimated 40% had likely positive lymph nodes, but only 14% developed node positive disease. So what we felt was that not all node positive disease caused clinical significant disease. So again, these were patients that just had a total mastectomy, did not do the lymph nodes at that operation, but we would wait and see whether they would develop disease later on. There's the B06 data. Again, this looked at just comparison of mastectomy versus lumpectomy with radiation. And so you had three arms. You had a total mastectomy, axillary dissection, lumpectomy with axillary dissection, lumpectomy with axillary dissection plus radiation. And so there's 20-year data that we have of this. And so we still see that there's no difference in disease-free survival, no difference in distance disease-free survival, or no difference in overall survival between all three arms. And so this kind of told us a lot that the difference in survival is really not beneficial to do a mastectomy if you can offer a patient radiation. And they want to have breast conservation with a lumpectomy, the survival does not change. And so this has sort of changed, management and how we take care of the breast with the use of having radiation treatment. B32, so this is looking more and more into the sentinel node. And Loma Linda, we were able to actually participate in the B32 study. I remember as a resident, when I was an intern and second year, we were actually enrolling patients in this study. So the question here was, in someone that is node negative and they're having breast conservation or so, does sentinel lymph node achieve the same survival and regional control as axillary lymph node with fewer side effects? So essentially really looking at sentinel node dissection versus axillary, because still at this time, a lot of patients were still getting axillary lymph node dissection. So between 99, 2004, so I was in residency 2003, so we were at the tail end. I recall enrolling patients in this study when I would operate with my faculty. So they had two groups. There's the clinically node negative. All of them had to be clinically node negative, so they would get sentinel lymph node. And then everyone would, in this arm, they would get, again, randomized arm. So you would get sentinel node and then axillary. And then the other arm was sentinel lymph node, and you would only get an axillary node dissection if your sentinel node was positive. So this is the breakdown of these patients in the schema. And what we saw in here between the two groups, there was no difference in overall survival, 5 years, 8 years, and even 10 years, there was no difference. No difference in disease-free survival. So this study really launched, sentinel node dissection as an alternative to doing axillary node dissection in every patient. And so as you can see, the evolution of axillary care is to de-escalate how much surgery we do in the axilla without affecting overall disease-free survival to decrease morbidity. So when we look at the endpoints, overall survival, there was no significant difference between the arms. They did say morbidity was significantly less with sentinel node biopsy alone versus axillary. I believe the risk in sentinel node biopsy for lymphedema tends to be about 3 to 5%. And with axillary lymph node dissection, it looks to be almost over 20%. It's what I've seen a lot of literature quoting. And when you add radiation onto this, it goes up even higher. The false negative rate was about 9.8%, and we were using two dyes, so we were using technetium 99 and blue dye. So one of the largest study, this study, ACOSOG Z11, was also very transformative in breast cancer care. So this was done by Dr. Giuliano, who's at Cedars Medical Center in Los Angeles. And the question here, and this was sponsored by the American College of Surgery Oncology Group. So in looking at patients who are, early stage breast cancer, who undergo a lumpectomy, as we're doing more and more, breast conservation, and who get whole breast radiation, does axillary lymph node improve survival or local control versus observation in patients that have very limited sentinel lymph node disease? So this had, phase 3 study, 115 institutions. They closed their accrual quite early. But the data, there's not going to be, we've discussed this quite a bit, but it's unlikely to be another study similar to this. So this was the breakdown in the arms. They had 891 patients. They did not achieve what the total number they wanted to have, but they had enough to at least show that there was that the study was a very good positive study. So what we found was that when patients compared to axillary lymph node dissection, again, this is when you have breast conservation, versus sentinel dissection alone, there was no difference in survival in a select group of patients that had node positive disease on the sentinel node. The same thing with overall survival. So what we see is the following from the Z11, and it's very specific with a specific group of patients. So early stage, T1 to 2. So T3 disease was not included in this. Node negative patients undergoing breast conservation. And so if we on sentinel lymph node dissection, we saw 1 or 2 lymph nodes that had some disease, the data show that you can leave those patients alone and not do an axillary dissection. There was question of whether if there's extranodal extension, so a large amount of extranodal extension that they would consider grossly positive. And oftentimes some of the patients with significant extranodal extension would end up getting an axillary dissection. And many of these patients we knew were also hormone positive, and we found that we're able to actually now, from NSABP B32, now with ACOSOG Z11, we're able to actually stop doing axillary dissection, even if there's very limited sentinel node positive disease. So part of the thoughts is that, we're using radiation, and when we look at the BO4 data, patients who had total mastectomy and radiation, even in the setting of clinically positive lymph node disease, did not fare worse with patients who had radical mastectomy. And then this holds to the fact that radiation does play a role in the axilla to help control disease. And so, again, these patients have to get radiation. We use external beam radiation in these patients as well. The AMAROS trial. So ACOSOG Z11 was specifically for breast conservation. The AMAROS study was specifically included every patient, included mastectomy patients, because at that time, we still didn't have data for what if I have a mastectomy? Because not everyone that gets a mastectomy, always you're going to do radiation, but everyone here, when we're going to do breast conservation, they get radiation. So here it was very similar. In lymph node positive disease, again, very limited lymph node positive disease, does axillary radiation have comparable regional control with less morbidity? So this was a phase 3 study, 34 institutions throughout Europe. Again, very early disease, T1 to T2, node negative disease, breast conservation. Again, also whether it's breast conservation or mastectomy, but we looked to see whether they had a small amount of disease, so 1 to 2 lymph nodes positive. So, even in mastectomy, we see that if we're going to use radiation, it's going to be in the setting where there's node positive disease. So patients, we looked at whether they got an axillary lymph node dissection versus axillary radiation. So this is the breakdown that we had here. So patients assigned to axillary lymph node dissection, patients assigned to axillary radiotherapy. And we found that there was no difference in in disease-free survival, and no difference in overall survival. We also saw that there was less lymphedema after axillary radiation versus lymph node dissection. So it helps us now in patients who are getting mastectomy that we can utilize radiation in very limited axillary disease to still avoid doing an axillary lymph node dissection. And so these were kind of the summary endpoints of that study. So I want to kind of pause and kind of go back a little bit. So that's kind of the evolution of patients who are clinically node negative. We do surgery. And can we look to de-escalate disease in patients who have no palpable lymph nodes and no biopsies showing that there's cancer in the axilla? And so that kind of dovetails in the sense of, well, we're able to do that. We have enough data to show that in clinically node negative, we can avoid doing significant axillary surgery in patients, in those patients. We can just leave it as an axillary lymph node dissection, or sorry, just a sentinel lymph node biopsy. But then the question then comes to, what about the neoadjuvant setting? And so I was just going to touch on a couple of things in the neoadjuvant setting, and then I'll end with probably the last 2 studies that are looking at patients who have node positive disease and how do we manage that in the axilla. So real quick, looking at hormone positive and HER2 negative disease, triple negative, HER2 positive disease, and the things that we bring up are, what are the benefits to upfront chemotherapy? Well, one thing we know is there is significant downstaging of disease in the breast, and we actually have seen this even here in our practice of downstaging of disease in the axilla. We can convert many patients who, prior to getting chemotherapy, would need a mastectomy, and we can convert them to just getting a lumpectomy. And if they're able to get radiation, then even this also works well for them. There's also, again, the potential for de-escalation of axillary surgery. So we've converted an axillary lymph node to just a sentinel node. When in evaluating this, sometimes we will do a targeted lymph node dissection, but we've been able to at least take bulky disease in the axilla in some patients and reduce it to almost sometimes even clinically node negative, and we'll sample some of these lymph nodes, and oftentimes we find no cancer left. So there's a couple studies looking at those patients specifically. So real quick, B18 is kind of the one study that looked at neoadjuvant treatment. They looked at patients who are T1 to 3, N0 to N1, M0 data, neoadjuvant versus adjuvant chemo. Patients had either a lumpectomy or axillary lymph node dissection or a modified radical. And the point of this study was to see what effect does chemotherapy have on these patients. One thing that is held true is that when you look at the whole groups on a large scale, overall survival and disease-free survival does not change. But what we do see is that patients who had a either clinical complete response or even better, a pathologic complete response, we see it improve disease-free survival. So if you look here, overall survival and disease-free survival both were improved. So these were the patients, 85% overall survival compared to 73. So these are the patients that had neoadjuvant treatment. And disease-free survival, these are the patients that had neoadjuvant treatment. And B18 showed there was even a significant reduction in death in some of these patients where you gave chemo up front. They tended to see a trend in disease-free survival improvement on women less than 50. So overall survival 71 versus 65%. So p-value of 0.04. Disease-free survival is very borderline. So B18 kind of held us to a level of, well, we can definitely use this in many ways to see how the biology works in these patients, and potentially for a subgroup of patients, they may actually live longer and do better with getting chemo first. So looking at neoadjuvant versus neoadjuvant endocrine therapy. So this is a study, it wasn't a title for the study, but these are the authors here. These are postmenopausal women who had T2, N1 to N2 disease, or T3, N0 to N1 disease, or even T4 disease. Hormone positive, they randomized them to getting neoadjuvant chemo or neoadjuvant endocrine. And the endocrine therapy is either anastrozole, so aromatase inhibitor, or exemestane. And then this was the surgery. So most of these patients either had modified mastectomy or breast conservation therapy, but they all had radiotherapy. So this was much more advanced disease type patients, and using neoadjuvant chemo to see if they can have downstaging. And what we found, and this is some of the pictures from that study. So these are patients beforehand. After treatment, you can see on the mammogram post-treatment, significant reduction of disease. So clinical response were similar in all three groups. So chemo, anastrozole, or exemestane. They did see a greater percentage of patients receiving neoadjuvant endocrine therapy to achieve breast conservation therapy compared to neoadjuvant chemo. And this is important because we've seen patients get chemo, and many patients even that I have that are older, they don't want chemo. And chemotherapy, we know the cytotoxic chemotherapy is very hard for patients to get or to deal with a lot of the after effects, and it just makes them oftentimes just very tired, and their quality of life is not as good. So this study and even subsequent studies after this have said, endocrine therapy in hormone positive and HER2 negative disease may actually be beneficial in many patients that are postmenopausal. So a lot of our practice has slowly been moving toward utilizing more hormone-based therapy in the neoadjuvant setting than full chemo. A couple other studies that have looked at this, the IMPACT study. Again, all of these have just added to the literature. The IMPACT study and the PROACT study, all of this have added to the literature to say we can utilize aromatase inhibitors in these postmenopausal patients more than tamoxifen. In our premenopausal patients, we probably tend to use more chemo. Even if they're hormone positive, we definitely see a much better response to chemotherapy in our premenopausal patients than postmenopausal. ACOSOG, the 1031 study, this was a phase 2 study. This was a fairly large study. Again, looked at patients on different types of endocrine therapy. So exemestane, letrozole, anastrozole. And what this study showed is letrozole tends to have a better effect when it came to clinical response rate. And so more often now I see a lot of my patients getting letrozole as far as neoadjuvant as if they have advanced cancer and they're postmenopausal. And if we're going to plan on neoadjuvant in the initial stage, more often when I use neoadjuvant now, it's usually if they're in the postmenopausal setting, it's, if they have node positive disease or they have T4 disease or very large T3 disease. So triple negative therapy, some of the updates on here in the past, triple negative breast cancer was really just treated with chemotherapy, but now we have more data looking at immunotherapy plus chemotherapy. So looking at immunotherapy in the aspect of inhibiting PD-1 and PD-L1, that interaction. So the two drugs that have been utilized quite a bit in triple negative breast cancer is atezolizumab and pembrolizumab. So there are two studies, I-SPY2 and Keynote 522, that looked at this. So I-SPY2, this was a phase 2 randomized controlled trial looking at stage 2 to 3 breast cancer. So patients were either getting paclitaxel plus AC, so standard chemo for these triple negative patients, versus paclitaxel and AC and immunotherapy. And so what they saw is that in the 69 patients randomized to neoadjuvant chemo plus pembrolizumab, we had significance. We actually tripled the pathologic complete response in patients in this group of patients. So that added more to the literature that says these patients are going to benefit with getting immunotherapy on top of getting chemotherapy. The Keynote study looked at stage 2 to 3, they did not include N3 disease. They had over 1,000 patients. They look at carboplatin and Taxol versus neoadjuvant chemo plus pembrolizumab. And again, we saw improved pathologic complete response in PD-L1 positive patients. And even if their PD-L1 was negative, we actually still saw a clinical response. So it didn't actually matter fully the PD-L1 status. But what we did see is that there was much higher response in patients who were PD-L1 positive. So real quick, looking at HER2 disease, there's the NEOSPHERE study, which was a 5-year study looking at pertuzumab and trastuzumab in patients with locally advanced inflammatory or early stage HER2 positive disease. So this study looked, again, here's the breakdown of how the study was done. They had about 417 patients. And the arm that actually showed the highest pathologic response was this one, the THP. So this is the patients that had trastuzumab, pertuzumab, and docetaxel, so THP. This is what has now been used more and more now, this regimen in patients that are HER2 positive disease. If we're going to utilize neoadjuvant treatment in that setting, there is literature that shows, though, in potentially early stage HER2 disease, like very early stage, there may not be a full benefit to using neoadjuvant treatment. Some of these may be able to go straight to surgery, but the more advanced disease patients, we will tend to use neoadjuvant treatment in HER2 positive disease. Okay. So this is kind of the results and breakdown of the NEOSPHERE study. So what are some of the other things we can look at neoadjuvant? So people were getting concerned when we do neoadjuvant chemotherapy, that can change the lymphatic drainage in the axilla. So ACOSOG 1071 came out to really look at this. So what is the main question is, what is the false negative rate for sentinel node biopsy after neoadjuvant chemotherapy for people who are node positive disease and breast cancer? So phase 2 study, 136 institutions, so 2009 to 2011. And really what we looked at in the study, and this is the breakdown of the study, 701 women met eligibility criteria, underwent axillary surgery. We had a certain amount who had N1 disease, some who had N2 disease, but they all had sentinel lymph node biopsy performed. and then women who had, N1 disease had greater than one sentinel lymph node detected, and they also completed axillary lymph node dissection. Again, really to see what is the false negative rate in patients having neoadjuvant chemotherapy. Most of the patients had dual mapping agents, and we wanted to make sure we got at least 2 sentinel nodes. So using blue dye and the radio-labeled colloid, so that would be, technetium-99. And then what we found is that the false negative rate actually tended to be significantly less in patients who had dual agent mapping, so this right here, and if we got at least 2 lymph nodes. So that literature held to this, saying that in the neoadjuvant setting, you can still use sentinel lymph node dissection, provided you utilize dual mapping, and it becomes much more accurate. So blue dye and radioactive colloid. The false negative rate initially was 12.6, which was higher than previous study as far as B32 went. But when we looked at specifically dual agent mapping, the false negative dropped down significantly. So we were able to, dual agent mapping and getting at least 3 lymph nodes, or 2 to 3 lymph nodes, actually more like 3 lymph nodes, the false negative rate would drop. Sometimes it's hard to get 3 lymph nodes, whether it maps out or not, but at least using dual agent, you're getting a false negative rate close to what we saw in B32 in patients who are not getting neoadjuvant treatment. So this held a lot of support that in the neoadjuvant setting, in patients who you're trying to downstage, or they've got a big breast cancer and they're inflammatory, you're trying to downstage this, or anything they're using to downstage, you can still be very confident in doing a sentinel node biopsy after neoadjuvant chemo. So I want to get to probably the 2 latest studies, and both of these studies are, Alliance study and B51. Alliance, I think, is complete. B51, I think, is also complete. We participated in both of these trials as well. But both of these look at, in the setting of patients who have node positive disease, and I give them neoadjuvant chemo, can I eliminate axillary and lymph node dissection? Because in most other studies, when we still get, prior to this, if we gave neoadjuvant chemotherapy and they were node positive even before neoadjuvant chemotherapy, even if they got downstage, we would still tend to take out a lot of the lymph nodes. But now more and more our practice has been changing. And so B51 and Alliance, even though the results are not out yet, we're seeing either preliminary studies or preliminary reports saying that we may actually be able to, even in the neoadjuvant setting, utilizing radiation, eliminate needing to do axillary lymph node dissection in patients who have node positive. So if you look at B51, and I'll show you the schema, again, this was 2013 to 2023, so this is still slowly enrolling, it's almost done. So patients that are T1 to 3, N1, M0, they get neoadjuvant chemotherapy, and it doesn't matter whether they get lumpectomy or mastectomy. With a sentinel node or axillary lymph node, we looked at utilizing regional nodal XRT versus no regional nodal XRT. So this is the schema. I like looking at this because it helps me break down how they're getting treated. So they looked at patients who were, again, ER versus PR status, didn't matter. All of these were involved, but the randomization took place in no regional nodal radiation versus regional nodal radiation. And these would be patients that after chemotherapy, you had a node negative status in the axilla. So if I did an operation and I did the sentinel node biopsy, so they were, let's just say they were node positive before they got chemotherapy, and then after chemotherapy, they were node negative, then we would stratify them to getting no radiation versus radiation. So again, we're still waiting because we probably won't get much of this results till 2028 because the study is still finishing off. But what we're seeing is that this literature may hold true that we can eliminate doing a lot of axillary surgery in these patients because in neoadjuvant setting, because we're able to utilize radiation. And this goes again to a lot of what we saw in B4. The Alliance is another study. So this is also a phase 3 trial looking at axillary node dissection plus radiation versus radiation alone in earlier stage breast cancer with node positive disease. So similar group of patients as to B51, same sort of setup where they get lumpectomy or mastectomy. This one, I believe, it says 2024, but I believe it's actually not enrolling much anymore. So if you look at this schema, so a patient here, T1 to 3, N1, they get neoadjuvant chemo, mastectomy or lumpectomy, and we do sentinel node surgery at that time. If their sentinel node is negative, we can actually then take them and enroll them into B51 to see whether we just need to do nodal radiation or regional node radiation. And again, these patients have to have had a good clinical response. So I've had patients where we will give chemo, and I've had probably on a handful of patients where the response was not that great. And I could still palpate bulky disease. And those patients, they would not be eligible for the study. So those patients would still get an axillary dissection. But if you look at the Alliance study, if the sentinel node was positive, they were randomized to this. So again, this would be, you give chemo, they are going from node positive clinically, and then we do a sentinel node because they're still have had a good clinical response. So I don't feel palpable lymph nodes, but the histology still shows that there's cancer in the lymph nodes. And so if they're node positive, we would randomize them to axillary lymph node dissection and nodal radiation without the axilla, or no axillary surgery at all. And just radiating, so basically no axillary surgery and just using radiation. So we're still waiting for a lot of the results of this study, but we've learned to try to extrapolate certain data from this and see what our practice here at Loma Linda would be. And so again, we're still waiting for the results. They're hoping to enroll close to 3,000 patients. And again, all of this is really to decrease that picture that I showed you of just significant lymphedema and other complications without affecting overall outcomes, cancer outcomes in these patients. So what is our practice here that we've taken on at Loma Linda? So with a lot of the population that we have patients who have not the best access to healthcare, and to the patients that have lots of great access to healthcare. So we tend to try to get as many patients to do breast conservation. So it's quicker recovery. Again, but that's provided they're able to get radiation. And so there are small groups of patients that can't get radiation, so they can't go that route. We tend to do more wireless localization. And then some patients, we can do breast reduction surgery with plastics. And we know with breast reduction surgery, less breast tissue, there's also a slight reduction as well in breast cancer recurrence in some of these patients. We'll use sentinel node biopsy for invasive disease. So for DCIS in breast conservation, we never do the sentinel node unless something shows up later on. And then radiation therapy. So we use, stereotactic radiotherapy in patients who are node negative. So at Loma Linda, we have proton therapy, so we've used that quite a bit. And if they have node positive disease, then we use external beam. And so we tend to follow what is done in the AXOG Z11 study of how we manage breast in breast conservation surgery. Again, these are clinically node negative patients before treatment. In mastectomy, many patients, if we have the option and they want breast reconstruction, we'll do that, but that's making sure you have plastic surgeons available, and we tend to do the reconstruction at the same time. Some patients get reconstruction down the road. Sentinel node biopsy, again, for only invasive cancer. If I have a patient who has ductal carcinoma in situ and they're getting a mastectomy, I generally will not do the sentinel node biopsy. And the reason being is there is literature from Memorial Sloan Kettering now that says that even in the setting of mastectomy with DCIS, if you find invasive cancer, you can actually still do a sentinel node biopsy using just by injecting the skin flaps. You can still localize the lymph nodes after surgery. And so that's generally been my practice now in DCIS patients who are getting mastectomy. I leave the lymph nodes alone till after surgery. We generally will use post-mastectomy radiotherapy, again, with node-positive disease following AMRO study. And many patients who have T3 disease are going to get radiation as well after surgery. What do we do in node-positive disease? So in hormone-positive, HER2-negative, we moved on to utilizing more neoadjuvant endocrine therapy or neoadjuvant chemotherapy. Can tend to be very patient dependent. We use more chemo in younger perimenopausal, premenopausal patients. Triple negative, we moved to using neoadjuvant chemo plus immunotherapy. And then in HER2 positive disease, we're using the THP, so Taxol, trastuzumab, and pertuzumab. And so they get chemotherapy like 6 months up front. When they finish their chemotherapy, then we go to surgery and they continue for a year on immunotherapy. And then we've looked more and more to de-escalate axillary surgery in many patients. So often what we do is when we biopsy the lymph nodes, we'll put a seed in the lymph node, or sometimes you can use a wire localization. And what we do is when we do the operation, we'll do what's called a targeted lymph node dissection, where we will excise that lymph node that had the biopsy, proven breast cancer. And on top of that, sometimes we'll do a sentinel node biopsy, but there's more literature coming out now that this targeted lymph node that had the cancer before you started chemo will always generally be part of the group that does a sentinel. So it will likely be we just don't bother with doing a targeted excision and just stick with, after neoadjuvant chemo, just doing still a sentinel node biopsy. So that's what I have for you all today. Would love to answer any questions that anyone has on what we're doing here as far as breast cancer therapy. And I know it's a lot different in other countries when I talk to people of like, how do they manage different cancers? Because a lot of this has to do with resources, barriers, and screening, and how do we get patients all the resources we need in order to start treatment.
Okay, thank you for this updated presentation, and let's start by taking some questions. I have a question myself.
Yeah.
In your daily practice, what's the percentage of mastectomies you still do? Like if you have 100 cases, how many of those would be mastectomy and how many would be breast conserving surgery?
Probably 40. It's not greater than 50. And probably the majority of women that want mastectomies, a lot of them are still the younger patients that I have. So under 45 years old, many of them still want mastectomy because we now are able to offer much more complex reconstruction. And so because of that, and again, we're also testing them when they're younger. So if they're genetic test positive, then they're going to get mastectomy. But I would say it's about 40%, no more than 50% of patients that still get mastectomy. Most of that is not because we can't offer breast conservation. It's just patients get very, very worried and stressed about breast cancer, and it's understandable why. Because many of them, the biggest argument they use is, well, you do that operation, and then what if it comes back? And we have data to show that the recurrence rate and I explain this to many patients, the recurrence rate is still very minimal difference between mastectomy and lumpectomy with radiation. But I think I end up doing oftentimes mastectomy just because patients are just more worried than actual cancer reasons.
Okay. If you have a question, please raise your hand. Start by Dr. Madhat Kafagi. Dr.
Kafagi? Yeah.
Yes. Thank you for your lecture. How about the male breast cancer? We observed that lymphedema, I didn't see any lymphedema in these patients after axillary dissection. Do you routinely do axillary dissection in them, or you follow? What's the difference in treatment between males and females?
So I've had a couple males, and most of the literature didn't talk a lot about the males, but so one, we've seen them present more advanced. So most of the handful of males that I've done breast cancer management, they were node positive. So we gave them all chemotherapy. At least in the couple that I did, most of them still got an axillary dissection. And a lot of that was because that was before some of the more current literature was coming out. But we tend to manage males similar to females as far as what we do in the axilla. But they tend to present much more advanced because, you know, most of us men, we don't think that we're going to get breast cancer, but we have breasts. And it's just the numbers are much lower. But yeah, I mean, I would say, I'm just thinking off the top of my head, I think probably half the men that I treated with male breast cancer who had cancer in the lymph nodes, they got an axillary dissection.
Thank you.
Do you see a significant larger portion of males in Egypt with breast cancer?
No. It says 1 to 30 or something.
Okay.
But we do a routine axillary dissection because I have more than you have for a long time. I have about in my career about 6 or 7, but no one developed lymphedema. I don't know why. After axillary dissection.
Yeah.
So I routinely do axillary dissection.
Okay.
Yeah, I didn't see a lot of literature showing the risk of lymphedema that is in Egypt as far as getting axillary dissection. I didn't find that.
No, that is the same like you have.
I think it's so maybe you noticed that the lymphedema doesn't occur as much in males. Is that what you're saying?
I
I'm
think
not
because
sure. No, I'm not sure if it does occur less in males. I think it really just depends on how aggressive you do the dissection. I think in the past, everyone would just completely skeletonize the vessels completely. And now, I mean, even when I do this, I take what I feel is bulky disease, but try to leave as much of, you know, adventitia or whatever I can around the axillary vessels, just so there's some lymphatic drainage. So I think Dr. Fadlala or.
Okay, Dr. Walid.
Okay, thank you, sir, for your kind presentation. You hear me well?
Yeah, we can hear you.
Yes.
Okay. Just I have a few questions regarding number one, regarding the oligometastatic disease. Patient with breast cancer with just bony lesion, just 1 or 2. We start neoadjuvant treatment, and if still or resolve disease, we offer them a surgery.
Yeah.
When you start, when you consider an oligometastatic, this is my number one question.
Okay. So yeah, in oligometastatic disease, we know that bone-only disease, when they get neoadjuvant treatment, they do actually very well when you still manage the primary. So I will still operate on those patients. If they have oligometastatic in the liver, I've had a couple. And after chemotherapy, if they've responded well, I'll operate on those patients. Because I do believe that there is still some level of, you know, theoretically, but we think theoretically there's still some aspect of the primary site either seeding the rest of the body or, you know, still contributing to other disease sites.
Yes. Okay, sir. Number 2, regarding the contralateral axilla. Maybe you have a breast cancer, and then we have a contralateral axillary lymph node. We take a biopsy, it is positive, and the other breast, no lesions, and the hormonal profile is the same. You consider them as a metastatic disease or local regional, and you can give neoadjuvant and then go for axillary clearance for this contralateral axilla, or you consider it is a metastatic and it will not get benefit from surgery.
That's a great question. I mean, that's a very small group of patients, but yeah, so the way I understand your question is, if I have the biologic and histologic same breast cancer on the right side, and I see axillary that's confirmed it's the same on the left side, I mean, I consider that stage 4 disease. You know, I'll still treat them with neoadjuvant treatment. And what I usually end up doing is, depending on how they respond clinically, if they respond very well clinically, I will
Yes.
sample the lymph nodes, and if there's no cancer left, I leave it at that. Because we know that stage 4, their biology is going to be more aggressive. So if they're going to show up elsewhere, the biggest way to control a lot of stage 4 disease is systemic treatment. And so
Yes.
they're not going to die from, more often, from cancer coming in the breast or here. It's going to show up in the liver, the lung. So we just say, why subject them to major surgery to prone them to lymphedema?
So you avoid surgery, even if after chemotherapy there is still lymph node in the contralateral axilla.
Yeah, we'll do a sampling. We'll do still like either a sentinel node or just sort of a targeted minimal dissection, but not a full axillary dissection if they responded well.
Yes. Okay. My last question regarding the complete response patient or complete responder patient. Then maybe we just plan for this patient a neoadjuvant chemotherapy, and then we will go for mastectomy. Okay. And then after she started the neoadjuvant chemotherapy, there will be a complete response. So there is no tumor in the breast, no tumor in the axilla, and now we have to do a mastectomy or radical mastectomy, and we know that the axilla and the breast oftenly will not have any tumor.
Okay.
Can we offer another option for those patients? Because we discuss with them that we will do a mastectomy and the pathology will be no tumor.
Yeah, so in a lot of these patients, even when we use neoadjuvant treatment, we'll assess them clinically either by exam or imaging.
Yes.
And if they are clinically responding, whether we won't have a pathologic answer, but if they're clinically responding, I will still opt for breast conservation if they want. And even in the axilla, if they have good clinical response, I'll do a sentinel node just to assess the axilla. I won't go into an axillary dissection.
Yes. This is very important. But for this patient, maybe we don't put a clip as we planned for mastectomy. So it is difficult to localize where is the tumor. How we can do in this scenario?
I see what you're saying. So, in the breast, what we do, we always leave a marker. So when I biopsy the breast, we put a clip in the breast during that biopsy so we know where the primary site is. So I can then localize that to do breast conservation.
But you do it routinely, even if the patient will do a mastectomy. Routinely, okay.
Yeah, it is routine in the country to anytime you biopsy the breast for anything, anything that's suspicious looking that get a biopsy, they put a clip in there.
Yes, our management, because we have to limit our resources,
Yes.
So we put a clip when we managed or planned to, we'll do a conservation. But for this patient, we'll have a mastectomy, we don't put a clip. So we follow this scenario.
Correct, and that can be the struggle, I know, in different places depending on the resources. So, thank you.
Thank you, sir. Thank you. You are a great help.
Thank you.
Okay, Dr. Ahmed Ismail.
Thanks, Dr. Hisham. Thanks, Dr. Solomon, for your comprehensive presentation. My question, in the view of ACOSOG Z11, what is the current practice regarding early stage breast cancer, early stage hormonal positive with 1 or 2 sentinel lymph node positive biopsy, either micro or macro metastasis? What is the current practice? Do you omit both axillary dissection and radiotherapy? Do you still offer dissection, offer radiotherapy? What is the current practice and recommendation in your hospital and in USA?
Yeah, so in our hospital, in most places around the country now, we follow Z11. So if a patient's going to get breast conservation and I do the sentinel node biopsy and they have 1 to 2 lymph nodes positive, like you say, they're hormone positive, and there's no, significant extranodal disease, I do not do an axillary dissection. They're good because these patients will end up getting external beam radiation, and so we use that. And they'll get systemic therapy, whether it's, adjuvant endocrine therapy or systemic chemotherapy, and we've seen no difference in survival. So most institutions now in the country, and we train our residents this way, we follow specifically what Z11 will discuss.
Either micro or macro metastasis, doesn't matter?
Correct. The biggest thing is extranodal. So there was a thing about extranodal extension. So when we have extranodal disease that is like grossly positive on the lymph node, those patients, they'll get an axillary dissection. But that is not a very large group of patients that was seen in Z11.
Okay, thanks.
Dr. Amr Khalil.
Okay. Dr. Hisham, can you
Yes,
hear?
go ahead. Yes.
Okay. Thanks, Dr. Hisham. Thanks, Professor. My question about bone scan. Is it mandatory for evaluation metastatic workup, or is there a specific indication for doing bone scan pre-operative breast cancer surgery?
That's a great question because, there's the NCCN guidelines oftentimes will say, order these tests depending on the clinical symptoms on patients. So our practice here has always been, if we're gonna, whether it's after surgery or before surgery, sorry, excuse me 1 minute, I'll get back to that.
Okay.
All right, sorry about that. So yeah, so bone scan. So NCCN guidelines tend to say if they have symptoms, then get these other studies. But more often, if I've operated on them, they're node positive disease, I'm going to start chemo. My traditional thing has always been CT, chest, abdomen, pelvis, and bone scan, regardless of symptoms. But depending on the environment which you have, bone scan tends to be more likely significant if they have bone pain or anything like that. Oftentimes on a CT scan, you may see something in the bone that could be potentially metastatic disease. So I think you have to use more aspects of clinical situations with patients. PET CT is another option that we've started utilizing instead of getting the chest CT, chest, abdomen, pelvis, and just doing a PET CT, because that will also look at the bone disease, but and it eliminates other tests. So that is another option to have, again, depending on what you have available, if you're able to utilize that. But in situations where you're not, I think just basing on clinical symptoms, deciding what to do as far as a bone scan goes.
What about alkaline phosphatase management evaluation pre-operative? Alkaline phosphatase, if it's high in some center, they prefer to do bone scan. What about your opinion?
Sorry, what was the first part you said about the bones?
Alkaline phosphatase.
Oh yeah, alkaline phosphatase. Yes. So I mean, if we see those elevated, yeah, I mean those are the clinical, signs and symptoms and labs to see whether we should do a bone scan in patients. Correct. We would use that.
Okay. Dr. Gamal Amira.
Thank you for your very nice lecture. My question is, when you give neoadjuvant chemotherapy and the disease vanish or complete response, don't you think to make the wait and watch policy as we do in the rectum or in the esophagus when we get complete response, clinical and radiological?
That's a great question. we've not had many literature studies to look at that specifically in breast. And even in the rectal cancer studies that they did in Brazil, it's still a very specific patient. So, they still will go and rebiopsy to see, is there any disease left? And so there's an aspect of clinical response where I think we see, radiologically, we don't see anything, we don't feel anything, but on the microscopic level, that's the answer we don't have. Now, whether we can do full wait and watch in breast, that who knows, that will likely be the next stage in the future. But right now we don't do wait and watch. If we get a good clinical response and we can do breast conservation if possible, or they want mastectomy, we'll still offer surgery.
Thank you.
Dr. Antar?
Do you learn me?
Yes.
Hello?
Yes, we can hear you.
I have one question. Okay, thank you. In my country till now, the sentinel lymph node biopsy is not available. In case of DCIS, when we did a simple mastectomy and we find in the final pathology is a micro invasion, must I go for axillary dissection or follow up?
That's a good question. So in the setting where if you don't have the resources for sentinel node, and you do a mastectomy for DCIS and you have micro invasion. So my bias in that tends to be in the setting with micro invasion.
Do you hear me, Hisham?
Yes, we can hear you.
Yeah.
Can you?
That's a good question. So in the setting with micro invasion after mastectomy, it would be very selective. I think older patients, I would likely just not do any more surgery and leave the axilla alone in that setting. A younger patient, I might do a sentinel node through the flap, but that's usually how I'll proceed. Now, I know in the setting where you don't have the ability to do sentinel node, the setting of microinvasion, I would probably hold off on still doing axillary dissection, because if you go to what the B4 data showed, you may not actually provide overall full benefit and survival by doing axillary dissection in those patients. And you can be very selective. If they develop disease later on in their axilla, then you can go and do an axillary dissection or other surgery later on. But I wouldn't do axillary dissection up front in the scenario you told me.
Dr. Antar is calling from Yemen, by the way.
Ah, okay. Well, yes, that's.
Do we have any other questions? Please, if you have a question, raise your hand. Dr. Walid? Yeah.
Thank you, sir. Just I want to ask about the central lymph node. Okay, you hear me, sir?
Yes.
Just regarding the technique of sentinel lymph node, you have a lowest number to retrieve during the surgery, and we encourage to take more than 3 to 5 lymph nodes just to make accurate staging. Just regarding if you have one positive lymph node over 1, you will be in doubt to have a Z11 or something like this. But 1 over 3 positive, it will give you, you can take a Z11 and then give a radiotherapy without doing extra dissection. So in your practice, how many nodes do you recommend to retrieve during surgery?
So, I mean, in my practice, when I'm doing sentinel node, in the setting of, let's just say, non-neoadjuvant chemotherapy, and it's just straightforward surgery, clinically node negative. I don't generally aim to take a specific number. I mean, there are times where I will just get one lymph node. But I will say that when I'm doing the sentinel node biopsy, I might get signal for one lymph node I'll remove. And if there's another lymph node that feels large or suspicious, I may take one or two extra. But then that's it. You know, I won't do anything more than that.
I just ask you because if you have the a patient for reconstruction, it is always very difficult to go again and make axillary dissection. So you understand me, sir? Just regarding for resurgery regarding the reconstruction after axillary attacking after reconstruction.
Yeah, in the setting of I've had some patients where I've had to go back to do an axillary, and I usually wait some time before they heal from their reconstruction, and then I'll make my axillary incision, and I can usually avoid, because everything's all nicely scarred in the reconstruction area. So once that's sort of scarred in and healed, then I can do an axillary dissection at that time. This might be, you know, a couple months, at least a month or so for sure, after their reconstruction. And so I'm able to at least get into enough of the axilla to do an axillary dissection. But I agree, it's not as easy, but it can be done. I think the key is waiting some time for them to heal from reconstruction.
And in the future, do you think that we will do axillary staging just by radiology ultrasound and in the clinic negative axilla, or just it's too far from now?
Sorry, I didn't hear the first part. What was it?
Just to do axillary staging with radiology, just by ultrasound. No need to go for sentinel node.
Yeah, I've done that at times. Yeah, no, I've done that at times. If I'll look at the axilla. Well, you know, a lot of times when we look at the axilla before, if we see something that's enlarged, we'll biopsy it. Because a lot of times it could be reactive, that you get a large node and it's not really positive. And I've had that before. But, you know, ultrasound can help in some settings to see what's going on with the lymph nodes. We've tried, you know, at Loma Linda, we actually tried to do something where we would, instead of excising the lymph node, we would use the ultrasound and our probe, and we would see which lymph node is the sentinel node, and then we would just take a biopsy of that lymph node. And so we tried that a few times. We had some success, but it's a technically very harder procedure to do.
Okay, thank you, sir. Sorry for engaging.
Oh no, appreciate the questions.
Okay, I guess that was the last question. So thank you, Dr. Naveen, for this wonderful talk, and hope you enjoyed it and enjoyed the discussion afterwards.
Of course.
And I will send you the video tomorrow.
Okay.
And if you have the time, we'd always love to arrange another webinar with you in the future if you have the time.
Yes, of course. I'll let you know when I can do another one. Okay, and we'll think of some other topics. So.
Okay.
We have the SSO meeting this March. I don't know if anyone from Egypt is going to Boston, but I'll be there in Boston at SSO.
I was there last year.
Oh, good. I'll be there this year. Let me know if you're there or anyone else.
Okay.
So, but hopefully there'll be some topics like we can expound and discuss from that meeting. So.
Okay.
All right.
Okay. Thank you, Dr. Naveen. Thank you, everyone, for joining, and have a good night.
Thank you all.
Bye-bye.